Welcome back to the third part of clinical tips for root canal treatment. In this video, I will be discussing about various clinical tips that will be helpful for dental students and clinicians while doing root canal treatment. This is the third part of the video. If you haven't seen the first two parts, kindly click the link in the description to watch those videos also. Before going into the video, kindly consider subscribing to my YouTube channel Smart Dentistry. I will make videos that will be useful for dental students and clinicians. In the first two parts, I have explained about 20 clinical tips. In this video, let's continue with tip number 21. Most of the practitioners are nowadays using apex locators. But one of the biggest confusion among them is whether the apex locator is working correct or is it showing the correct readings. In this tip, let us see about the technique to get the most accurate reading from your apex locator. Before going into the tip, let's understand that the basic working principle of apex locator. The advanced apex locators don't follow the same working mechanism, but for easy understanding, let's follow this mechanism which is partly correct. Apex locators send impulses in the form of electric current. This will travel through a connector wire through a file clip. This wire is attached to the endodontic file. The impulse now travels through the endodontic file and reach the tooth apex. Once the file comes in contact with the periodontal ligament, the impulse will start traveling through the oral tissues. This impulse is picked up by the lip clip which is attached to the patient lips and will be carried back to the apex locator. These readings are processed using certain formulas by the apex locator and the reading will be displayed in the screen. Now let's consider we are pushing the file little by little inside the root canal. Let's keep that in our mind. Now the file does not come in contact with the periodontal ligament or the periapical tissues. Now the conduction of impulse in the remainder of the canal is weak because the file is not reaching up to the apex and the impulse may be interrupted. This is calculated by the apex locator and the display will show us it is short of the apex. But keep in mind, if the apex locator is displaying a reading stating that it is short of the canal, maybe 0.5 or 1 or 2 mm short of the apex, most often the reading will be a wrong one. Yes, apex locator is usually wrong whenever it is displaying a reading which states that it is short of apex. At the same time, let's consider a situation we are extending the file beyond the apex. Now the impulses are better conducted and the chances for impulse impediment is reduced. So almost all the apex locators give a correct or most accurate reading if the file is extending beyond the apex. So if a apex locator is indicating that the file is beyond the apex, it will be always correct. At the same time, if the apex locator is indicating the file is short of the apex, most often it will be wrong or inaccurate. So what is the best technique to use the apex locator? Always push a small 10 or 15 size K file beyond the apex. Let the apex locator show the reading as beyond apex. Now shorten the file length little by little, not more than 0.5 mm at each step. At some point, apex locator will show the reading as apex. Stop there and note the working length. Almost always, this reading will be accurate. Even with a less expensive apex locator, if you are following this technique, you can get a very accurate reading with apex locator. So in short, go beyond the apex, reduce the length little by little. While reducing, at some point, apex locator will denote the apex. Notice that reading and set as the working length. It will be the most accurate reading. Tip number 22. This is a common doubt even for many experienced dentists. How to differentiate between a buccal canal from a lingual canal while doing root canal treatment in a radiograph. Let's clarify our doubt following this easy and very reliable technique. Before learning how to differentiate buccal from lingual canals, let's try to identify the canals in this radiograph, that is the obturation. There is a footnote along with this radiograph. This radiograph is taken from a mesial angulation. If you could name the canals 1 and 2, well and good. If not, in a couple of minutes, you can name it. Let's consider this as a teeth in mandibular jaw from canine to second molar region, and we are going to make a radiograph. We will focus the X-ray cone straight from the buccal aspect and we can get a high quality radiograph. At the same time, let's introduce two objects to the same radiograph. We are placing an object which is triangular in shape in the buccal aspect and an object which is square in shape in the lingual aspect of the teeth. Now we make an radiograph, and of course both the objects gets overlapped and it will be recorded in the radiograph. But this is the radiograph that we are going to get in our hand after developing, or the radiograph that will be displayed by a RVG. If someone is showing such a radiograph with such overlapped objects, it will be impossible to differentiate which object is in the buccal and which object is in the lingual. It is literally impossible. So what to do now? We have to follow a small clinical tip so that in all radiographs we can differentiate buccal from lingual. So before taking the radiograph, just tilt the X-ray tube around 20 degrees mesially. Now make the radiograph. Now instead of X-ray beam traveling straight, it will travel in an angulation. Now both the buccal and lingual object will be recorded in different place in the radiograph. They never gets overlapped. The object in the buccal side will be recorded in the radiograph distally, and the object in the lingual surface will get recorded mesially. So, if we give mesial angulation in the radiograph, the object which is present mesially in the radiograph is anatomically present in the patient mouth lingually. So, in this example, the triangle is present mesially, so in the patient mouth, it is located lingually. So, in this radiograph, square is present distally, so clinically it can be found buccally. Mesial angulation of the X-ray tube and mesially located object in radiograph is clinically present lingually. Always keep in mind, for endodontic needs, the requirement for distally angulated radiographs are very less. Probably we may have to take a distally angulated radiograph only when a mesially angulated radiograph is not going to give a well-defined or clear-cut ideas about the root canals, or maybe in case to differentiate between mesiobuccal 1 and mesiobuccal 2 in case of a maxillary molar. So in my view, it is always better to take a mesially angulated radiograph whenever more than one canal is present in a tooth. Now let's see the same radiograph which we have seen already. There is a footnote. This radiograph is taken from a mesial angulation. I hope most of you can now differentiate between the different canals in this tooth. So there are two roots, the mesial root and the distal root. In the distal root there is a single canal, so no confusion. In the mesial root there are two canals. Which one is going to be the mesiolingual and which one is going to be the mesiobuccal? That is going to be the confusion. So according to what we have seen so far, whichever the canal which is located mesially in the radiograph is actually present lingually. So this canal is a mesiolingual canal, and the canal which is located distally is a mesiobuccal canal. Let's see one more example. Here the differentiation will be little more difficult. This is a third molar root canal treatment. We can see two locations or two root canals can be differentiated. So the canal which is present mesially is a mesiolingual canal, and the canal which is present distally is the mesiobuccal canal, and this is the distal canal. I hope the concept is clear, and if you are making a radiograph, always give a mesial angulation and follow the same technique. It will be very easy to differentiate the canals. One problem that each and every dentist who does root canal treatment is, we might have given mandibular nerve block. The soft tissue, the lips, everywhere it might have got anesthetized. But if we are touching the tooth with aerator for preparing the access, the patient will be having severe pain. So this situation is called as a irreversible pulpitis or a hard tooth. In this clinical situation, it is very difficult to anesthetize the tooth, or the only anesthetic technique which could be used successfully in this scenario is an intrapulpal anesthesia. Let's consider this as a tooth, a mandibular first molar. There is a deep caries, and the first step that we have to give before giving an intrapulpal anesthesia is we have to remove the caries as much as possible from the surfaces, and then we can use a needle burr or a thin tapered fissure burr to create a small punch inside the pulp. It might be painful, but after giving inferior alveolar nerve block, the chances for pain to be felt with a needle burr will be quite less. So before making this, take a little local anesthetic solution in a small cotton pellet, and we can place it close to the preparation area, in the deepest area of your preparation. You can give little pressure, and it may not anesthetize, but for just making a small entry inside the pulp chamber, it will be sufficient. You can make a small opening inside the pulp chamber without much pain. Once a small opening is made, a thin needle, preferably a number 27 or a number 30 size needle, a small bend is given and it is forcefully pushed inside the pulp. Once it is pushed inside, around 1 or 2 drops of local anesthetic is injected. But make sure that if you are able to inject without much resistance, then the intrapulpal anesthesia is not going to work. Only if you feel and get a very good resistance, then only intrapulpal anesthesia will work. Make sure that you should get a good resistance while you are giving intrapulpal anesthesia. Intrapulpal anesthesia can be considered as the most effective anesthetic technique while doing root canal treatment, because instantaneously it will work and immediate anesthesia we can feel it within seconds. The next second we can prepare the access, we can proceed with our root canal treatment. There will be no pain at all. But while giving, for a second or two, there will be a severe pain for the patient. So without informing the patient about this painful sensation, never give intrapulpal anesthesia. We should always inform the patient that this procedure can be painful, but it will be lasting for less than 2 or 3 seconds. This will work only in case of a vital pulp. If you have diagnosed the tooth to be a non-vital, do not attempt giving intrapulpal anesthesia. Only 1 or 2 drops of local anesthetic is enough to anesthetize the pulp. And if the technique is improper and if you are not giving a good resistance while giving the injection, this technique will not work. Tip number 24. In many situations, in young patients especially, we may have to do root canal treatment. There is an easy technique by which we can remove the vital pulp completely without any remnants. Once we can remove that, the remainder of the cleaning shaping procedure becomes very easy, and the chances for the success from root canal treatment is increased manifold. You can see a picture. I have kept the pulp which I removed over a mirror. That's why you can see 2 images of the same pulp. This is a pulp which I removed from a young patient. He had undergone trauma and there was a Ellis class 3 fracture, and after a day he reported, and I have to do a root canal treatment. So the technique that we follow to remove the pulp completely, especially the vital pulp completely, is very easy. We need only one small instrument, then we can remove it easily. That instrument is called a barbed brooch. So this will look like a file, but instead of the cutting edges of the file, it will have small irregular barbs which is cut into irregular shapes. What we are supposed to do, we have to find a brooch which is little smaller than the expected canal size, and it is put inside the root canal. A small twist can be given and it can be pulled. So if you are doing this, inside this barbs, the pulp tissue will get entangled and the entire pulp tissue can be removed in a single stroke. It's a very easy and an effective technique. But the problem is, if we are using it improperly, this barb brooch may get fractured and it may be retained inside. And one more problem is, the small barbs which are present in the barb brooch may get broken off and it may get entrapped inside. So barb brooches to remove the vital pulp in toto can be used only in case of teeth which are having wide root canals. Tip number 25. Anyone who does root canal treatment must have experienced this in their lifetime. If someone says that they have never broken a file in their lifetime, probably they may have never done a root canal treatment. Root canal treatment and file separation can never be separated, but with the present day instrumentation and with utmost care, it can be minimized or prevented in most of the clinical situations. But still, with utmost care, if there is a file fracture inside a root canal, what to do now? There are certain situations or there are certain scenarios where the file fracture happens frequently. In the first situation, there is a file fracture which is of full length. Almost from the axis till the apical end, the file will get fractured. The certain situations at the orifice or in the middle third of the root canal, there will be a file breakage. This can be easily retrieved. In the next scenario, from the middle third to the apical third, there will be a file fracture. Again, this fracture can be attempted to remove using some advanced technique. Again, removal can be difficult in many situations. This is the most difficult and the file fracture that should never happen while we are doing root canal treatment. But this is the most common type of file fracture that happens. The file gets fractured at the apical end beyond the curvature. File fracture that is happening beyond the curvature will be very difficult or often impossible to remove it. So what we are supposed to do if there is a file fracture? One, we have to attempt to remove the file. If it is not working, we have to bypass the file, and if both of these techniques are not working, we can include the file as a part of the obturation and we can obturate the remainder of the canal after doing a proper cleaning and shaping. But again, in this type 3, the success rate of the root canal treatment may be compromised, and it will be mostly dependent upon the pre-treatment diagnosis. If the tooth was a vital tooth, then the chances for failure will be less. So let's see some of the common technique which can be used to retrieve a file. For example, there is a file fracture. First step is going to be, we have to widen the access cavity till the area where we can see the file tip. If the file had fractured close to the orifice, then this expansion of the access cavity can be done with an burr or if it is little deep, then we can use gauge slit and drill in order to widen the root canal. Once it is done, we can attempt to push a small file, preferably a 10 or a 15 size file, between the canal and the fractured file. In most situations, we will be able to push a small file sidewise to the fractured file. But always make sure that you use a new file out of the box. Do not use a used file or a old file for negotiating or attempting to remove a file. If we could go till the full length of the fractured file, you can just enlarge the canal and then you can irrigate, and you can do the same procedure little by little, and surely if you can go till the tip of the fractured segment, then we will be always able to remove the fractured file. But in certain situations, we will be able to bypass the fractured file and we may be able to go till the root apex. But the file which is present, that is the fractured segment of the file which is present, will never come out. It will be entrapped in between. But it is not a problem. If such a situation comes, and if you could go till the working length, leaving the file in the root canal is harmless. The success rate will be never compromised. If we could go up to the apex, we could do a proper cleaning and shaping and we could obturate. So removing the file and bypassing the file and doing a good obturation, even though there is a file separation, the success rate is not compromised. There is a technique which is commonly practiced by endodontists for removal of the fractured file. The access cavity and the root canal have to be enlarged up to the fractured segment. Then, with the help of a needle burr or a small ultrasonic cutting tip, the tooth surrounding the fractured file segment is removed. And after doing this, we can use ultrasonic vibrations touching the ultrasonic tip with the fractured segment of the file. The file usually will get loosened and it will come out. But in a situation, there is a file which gets fractured close to the apex, and that is beyond curvature, and we have attempted to remove by all the known techniques. Still we are not able to remove it. Then the only way that we could do is we can clean and shape the remainder of the canal and we can obturate. But keep it in mind, the success rate will be compromised. Tip number 26. One common cleaning and shaping error that happens frequently, especially in hand of an inexperienced operator or a beginner doing root canal treatment, is formation of a ledge. One of the biggest reason for creating a ledge is because of using a file which is bigger in size and rotating a file at a fixed length inside the root canal. Always keep it in mind, stainless steel files are never intended to be rotated inside the root canal. Stainless steel files are never intended to be rotated inside the root canal. Short of a working length, maybe at a curvature, then that's all. It automatically creates a ledge. Once a ledge is created, every time we push a file, the file will go, it will get hit at the ledge, and we can never clean and shape the canal which is present past the ledge. So what to do? First, if you are using a rotary instrument, stop using rotary immediately. If you are continuing to use a rotary instrument, the ledge will get aggravated. Second, do not use EDTA. If you are using EDTA in such a situation, we will never be able to bypass the ledge. The most effective technique for bypassing a ledge is to use a hand file after pre-curving. So take a small hand file, pre-curve, try to simulate along with the root canal anatomy and try to push the file close to the wall which is not ledged, that is the opposite side of the ledge. So take a small hand file, pre-curve it and go to the length where there is a ledge. Then give small right side and left side turns or rotations, small rotations, and then once if you are able to go to the remainder of the canal, do not remove the file immediately. So go negotiate till the full length without removing the file. Keep doing cleaning and shaping, enlarging. Make sure that the file becomes very loose inside the canal. So till then, do not remove. Once after you are very sure that you have enlarged the remainder of the canal enough, now you take it out, go with the higher size file with the same pre-curvature. There is a common habit. Once we could bypass with a hand file, next second the operator will take a rotary instrument and try to push. But again, keep it in mind, if you have created a ledge, try to finish the cleaning and shaping of that canal with hand file itself. Do not use rotary in such situations. It can aggravate the ledging. Tip number 27. Before doing obturation, we all make a master cone radiograph. What do we check in the master cone radiograph, and when we will come to know that the master cone that we have selected is right or wrong? I have put 4 scenarios in which we can see only the root tip and a master cone. The first situation, we can see that the master cone is around 1 millimeter beyond the root canal tip. In the second situation, we can see the master cone is around 1 millimeter short of the apex. In the third situation, we can see the master cone is up to the root tip. And in the fourth situation, we can see the master cone is around 2 millimeters short of the root apex. I am very sure out of these 4 clinical scenarios, one tooth is going to fail definitely. Which is that? I think most of you will be voting for the situation number 1, where the master cone is beyond the apex. I would say the situation number 3. Here we can see the master cone is up to the tip. This is what we will always look for. The master cone should be up to the tip. But look at on both sides of the master cone. There is a canal which is empty. So this area is going to be filled with the root canal sealer, and the root canal sealer, if it comes in contact with any liquid like the periapical tissue liquids, it will get dissolved within a month or 2, and it is going to leave an empty space. Even if you are doing a lateral compaction, the accessory cones may not reach up to the root tip. So this situation, it is going to fail definitely. Then what about the situation number 1? Don't you think it will fail? Yes, it can give some problem, but keep it in mind, Gutta-percha is a very biocompatible material. The root canal treatment will fail not because it is beyond apex. The root canal treatment will always fail if we are not able to provide a good fit or a tuck back at the root apex. A perfectly fitting master cone with a good fit at the apex, even if it is extending 0.5 or 1 millimeter, although it is not recommended to extend it beyond the apex, or ideally it should not be extending, and by some mistake, even if it is extending, it may not fail. But a good looking radiograph with a exact looking master cone but with these lateral spaces is going to fail definitely. What about the clinical situation of the number 4? Don't you think it will fail? It is a bit short of the working length. Maybe it is around 2 millimeters short of the radiographic apex, but in many situations will not create for an endodontic failure in long term. What we have to look for is a good tuck back. So what is this tuck back? Take a master cone, put it inside after cleaning and shaping. try to pull, it should never come immediately. There should be some form of resistance to it, and if you are pulling so much, it has to come. Giving a little pressure and pulling, it should offer some resistance at the root tip. That says that there is a close adaptation between the master cone and the root apex. If there is a tug back, then your treatment will be successful. A little beyond, little short may not create a problem, but not getting this tug back will usually create a problem and a clinical failure. Tip number 28. After preparing the access, cleaning and shaping, and if you are planning to give a intracanal medicament and send the patient back, we have to place a temporary restoration. Or after doing root canal treatment, we will be sealing the access cavity with a temporary coronal seal. So what temporary cement can be used for giving this closed dressing or a temporary coronal seal? From my point of view, zinc oxide eugenol cement remains as one of a wonderful material for giving temporary restorations. But there is a problem associated with all temporary restoration, not only zinc oxide eugenol. Let it be any ready-made temporary cement also. We will be giving a temporary restoration, and the next visit we will try to remove the cement. But it will be always difficult to remove the temporary cement completely. We can always find some of the temporary cement get stuck to the walls or the floors and it will never come out. While doing cleaning and shaping, what happens is this temporary cement sometimes gets dislodged and it will go and block the orifices. We may wonder, we were able to locate, we were able to do cleaning and shaping, suddenly the file will never go up to the apex. The reason is the temporary cement going and blocking the canal. So there is an easy way to avoid this from happening. Let's see a small video. I am using the zinc oxide and the eugenol, the conventionally available. Both are taken in a glass slab. We are going to mix it as usual. We will get a very good thick mix of zinc oxide eugenol. Take a small cotton wisp, 1 or 2 small cotton wisp or small cotton fibers of sterile cotton fibers. You can take it. We can incorporate those cotton fibers within the mix and then get a putty consistency, a thick mix of zinc oxide eugenol. It is always a good habit to take the zinc oxide eugenol after a good mix, kneading it in our hand. So I can ensure that this temporary mix is going to be one of the best temporary cement. We have placed fibers inside. So the strength of the zinc oxide eugenol will be manifold increased. It won't break, it won't go off that easily. Also, because of the presence of the fibers, if we are attempting to remove, we can remove the entire temporary material as a single mass. The chances that the temporary material gets stuck to the access cavity wall and being retained there is very less. Next time, follow this technique and I am very sure that you will be very happy. Tip number 29. Radix Endomolaris. In the last video, towards the end, I had asked a question and many had answered and many had personally texted me with the right answers. This is Radix Endomolaris. What is Radix Endomolaris? In the mandibular molar, there will be an extra root which will be present in the distolingual angle. So this is called as Radix Endomolaris. Why I have included this as a tip is, out of 100 mandibular first molar root canal treatment you do in a country like India, there are chances of 8 tooth having an extra root. The chances for Radix Endomolaris in South Asian population is around 8%. But most often we may tend to miss this. If we are taking a radiograph from a buccal aspect, we may be able to see the extra root between the mesial and the distal root. But anatomically, this root will be protruding out from the other roots. This root will have a steep angulation. The problem associated with Radix Endomolaris is, for example, if we are doing a cleaning and shaping for the distal canal, we can access the canal with the help of a file from vertically from the prepared axis. At the same time, if we are trying to access the root canal of a radix root, then there will be some curvatures which are formed. So this will make an acute curvature with that of the long axis of the tooth. So this will lead to formation of some bends or curvatures in the file. If you are continuing to do cleaning and shaping at this curvatures, the chances for the file breakage is too high. Doing a root canal treatment in the radix root without breaking the file is an art, because the chances for file breakage is too high. Even if it don't break at the canal orifice level, because of the double curvature presence, it can fracture. That is, the file can fracture even in the apical end, and even the apical end there will be an acute curvature. So we have to be extremely careful while doing cleaning and shaping for a radix root. So preferably do not enlarge the radix root so much, and if you could use hand file for the entire preparation, that is well and good. If you are using a rotary file, use a flexible file and do not force any stiff files inside the radix root. So in order to avoid this, we may have to extend the access cavity little more buccally than the usual access cavity, and we may access the file from the buccal angle instead of going from a straight angulation. So if we are accessing from a buccal angulation, then the chances for the file breakage can be reduced so much. So this is the tooth that we have seen in the radiograph. We can see the mesiobuccal, the mesiolingual and the distal canal orifices, and the radix endomolaris root canal orifice can also be seen. This tooth I did root canal treatment and it is finished like this. I went for a full coverage restoration and even the caries in the adjacent premolar was restored. And the last tip is when to do a single visit root canal treatment. There are certain clinical situations where we can do single visit root canal treatment. Probably in those clinical scenarios, single visit root canal treatment could give more success rate than the multiple visit root canal treatment. The first situation is traumatic injuries. In case of traumatic injuries, and if the patient is visiting the dentist within 2 or 3 days, most probably the pulp will be less infected and it will be vital. In those situations, we can finish the root canal treatment in the single visit. The second indication for a single visit root canal treatment is whenever we see a radiograph and canal looks without any complications, no calcifications, no abrupt curvatures. It is a simple, straightforward case. In these clinical situations, when there are no complications that you can suspect of, you can do a single visit root canal treatment even if the tooth is non-vital. So there is a misconception that all non-vital tooth must be treated in multiple visit and only vital teeth have to be treated in a single visit. It need not have to be. If you are practicing a good cleaning and shaping technique, not forcing the debris beyond the apex and using a good irrigation protocol, then single visit treatment can give equivalent success rate compared to that of multiple visit root canal treatment, even in case of non-vital teeth. The third scenario is whenever you find that giving a temporary restoration, doing a build-up, and all these procedures are going to be very complicated. Whenever there is a draining sinus tract or a traceable sinus tract is present, it is an indication for single visit. We may think that there is a pus discharge. We should never complete root canal treatment in a single visit. you are wrong. So whenever there is a sinus tract, it is a good indication that we can and preferably we should finish the root canal treatment in a single visit. We all come across people saying that they are too busy and they can never come for repeated appointments. So in all these situations, we can always go for a single visit root canal treatment. We may come across situations where many medically compromised patients will be visiting us. So those patients will be having so much difficulty for coming back again and again for the treatment. And also, for example, patients who require antibiotic prophylaxis for treatment, it is better to finish the root canal treatment in a single visit. Root canal treatment is always considered to be a painful procedure, and even most of the people are aware of that root canal treatment is going to be a painful procedure. Fear is one of the most important reasons that the patient delays or who will never report back to the dental clinic. So in order to avoid that, in the first visit itself, if we could finish the treatment, then the chances for missed or the delayed appointments in fearful patients can be prevented. Also, it is better to notice a lot of dentist time can be saved by doing single visit treatment. The time required for placing a temporary restoration and the next visit, removing the temporary restoration, applying a isolation and anesthetizing the tooth if needed, gloves, mask, suction tip and all these disposable materials all are going to be consumed twice. All this can be prevented by doing a single visit. In my practice, I preferably do single visit root canal treatment in most of my situations. I am very happy and I could provide a very good success rate with single visit root canal treatment. So request you all who are watching this video, whenever it is feasible, it is better to do a single visit root canal treatment. It will enhance your practice and it will also be easy for the patients. Root canal treatment is a series of steps together will lead to a successful root canal treatments like access preparation, working length determination, cleaning and shaping, obturation, post-endodontic restorations, and together we call it as a successful root canal treatment. If there is some problem happening with some step in root canal treatment, the success rate of root canal treatment is going to get compromised. While doing root canal treatment, respect the tooth, respect the patient, respect each and every step. There is no easy way for doing root canal treatment. The only easy way to do root canal treatment is by practice and respecting each and every step. Do not bypass any of the steps and give utmost care to each and every step. You can do a successful root canal treatment. Thank you for watching this video. Subscribe to my YouTube channel. Stay safe and be happy.